All right, thank you. I'm going to turn it over to Dr. Ha.
Thanks, Nathan, for a kind introduction as always. Let me just rearrange some stuff so we can get started. Sorry, guys. All right. Can you guys hear me and see the slides okay?
Yes, looks good.
Awesome. It's great seeing you guys, and some of you guys saw you in person at DW, so always a pleasure to see in real life from our Zoom encounters. So really good evening. I really thank the committee for allowing me to share this topic in terms of initial evaluation and management. My goal today is really to provide a framework for the initial evaluation and management strategies for early fellow. So especially those first years on the call, and then we'll focus on really specific recommendation and the data behind it, rather than like a generalized recommendation. And that way you can use to implement into your practice the next time you see a patient with fatty liver disease. So we'll get started. Just complete brief background. We all aware that the NAFLD is really the most common cause of chronic liver disease. Prevalence about 25–30% overall, and 30% in adults, and then 10–15% in children. And it's going to grow up to be the leading indication for liver transplantation. A lot of it's credit to Robert's work. Both NAFLD and NASH are associated with increased risk of cardiovascular disease, as well as liver-related morbidity and mortality, and impaired quality of life. The biggest really cause of malignancy, death for NAFLD is cardiovascular disease, as well as non-hepatic malignancy, just for the boards. And then for patients with NAFLD, there's actually a 5-fold increase in cardiovascular disease. So when we take care of these patients, we should have high index suspicion to make sure we rule out other cardiovascular issues. So NAFLD, this is the I'll implement the recent guidelines from AASLD into this talk as well. But NAFLD is really an overarching term. It includes all diseases of grading stage, 5% hepatocyte with macrovascular steatosis. Of course, in the absence of other causes of steatosis, we'll talk briefly later, and little to no alcohol use. And then in terms of population that AASLD recommends is really our patients who are pre-diabetic, who are type 2 diabetes, obesity with 2 or more metabolic risk factors, and some imaging evidence of incidental finding of steatosis. So these are kind of our population that we should counsel our primary care doctors, as well as us when we see them in our clinics. So as shown in this figure, NAFLD is really a spectrum disease that we all know. So simple steatosis is really the start of it. And it's really characterized with a macrovascular steatosis with no inflammation, as well as no hepatocytes. And usually 80–90% of patients really have no progressive disease over 10 to 20 years. And once the steatosis sets in, the inflammation causes resulting in NASH. And this is characterized by some of the other characteristic findings that we see with ballooning of hepatocyte, which is sort of like just unhealthy liver cells and can lead to fibrosis. So predictors of progression to NASH really includes advanced age, as well as sex, seen in postmenopausal women, as well as race, Hispanic, Asians, metabolic syndrome, as well as persistent elevated ALT. Really, the rate of fibrosis progression and hepatic decompensation really varies. It depends on baseline disease severity, genetic factors, individual environments, as well as comorbid. And it's really unclear what the percentage of NASH to liver cancer is in the absence of cirrhosis, likely due to just no screening guidelines. But just for the fellows on, especially the first year, I think that we always taught like the cirrhosis, the pathway, the natural history of cirrhosis to HCC, except Hep B, but also put NASH and NAFLD into that bucket as well. So along the spectrum of NASH, NASH is really the strongest predictor for hepatic fibrosis. And then hepatic fibrosis is really the strongest and most important prognostic determinant of liver and non-liver related outcomes. Therefore, it's really important for us to identify, or when we talk to our primary care colleagues, to really help identify what are patients at risk for these important prognostic factors. So how do we work up these patients? I think there's two pathway that I'll focus on. And this talk is really the AGA clinical pathway, and then the most recent AASLD one. So first is really want to identify the high risk groups that we talked about, right? So the 2 metabolic risk factors. These are like the type 2 diabetes, hypertension, hyperlipidemia, central obesity. And the reason why this is known is really there's a stepwise increase in the disease progression as well as HCC in these patients. This is based on a retrospective study looking at 270,000 patients. And then the other thing is type 2 diabetes, in the sense that there's estimated 20% of patients with clinically significant fibrosis also has type 2 diabetes. So we should really screen all patients with type 2 diabetes, and this is sort of the recommended guidelines for the ASD as well. And the other thing is hepatic steatosis or elevated liver enzymes. The reason this is important is because they see that 11% of patients with just incidentally finding steatosis may be at high risk for advanced fibrosis. And then the patients with steatosis as well as persistent elevated transaminase or liver enzymes is really an increased risk of progression to cirrhosis and HCC. So these are our kind of at-risk patients. We want to take a good history as always, and we'll go through the next slide, look at the labs and sort of workup. But you also want to get a really good alcohol history and make sure that we rule out alcohol given that these are steatotic liver disease. And then, so some of the things that we can do. The imaging, of course, ultrasounds remains really great modality. It's cheap, it's available, pretty good sensitivity and specificity. We'll talk about FibroScan and CT, MRI, PDFF next. But some of the labs for the earlier fellows, you want to get the viral hepatitis labs, of course, to rule out any other etiologies. The autoimmune labs, I think just note that the patients with NAFLD can have elevated ANAs, but they're pretty at low titers, and hence to differentiate the patients with autoimmune hepatitis from NAFLD is really high transaminase, greater than 5 times upper limit, high globulins, as well as high total protein to albumin ratio. And the other thing is like the ferritin. Sometimes we get these consults where how come the ferritin is elevated, and it's seen in about 20% of patients with NAFLD. So things that are, if it's really truly hemochromatosis, then its ferritin is greater than 400 to 500. Percent sat is greater than 40 to 45%. So we can narrow our differential. And of course, rule out the genetic factors. So then some of the other things that we talked about, I kind of left the slide here for the fellows just for boards. These are sort of secondary causes of hepatic steatosis, and making sure that we want to rule out macrovascular as well as microvascular causes as well. So our non-invasive tests, I think that this deserves really its own hour. There's a lot, and this is kind of where our field is moving towards, trying to prevent and avoid liver biopsies as much as we can. Really, there's as shown on this table, there's really simple, which is readily available biomarkers, as well as clinical characteristics, as well as complex, relying on biomarker of extracellular matrix turnover and imaging modalities. For interest of time, just want to cover maybe some of the main ones, which is the FIB-4, which is the one non-invasive simple test that's really abided by all the guidelines, AGA, ACG, ASD, as well as EASL. And then the enhanced liver fibrosis is because the ASD guidelines sort of adopted to that. And then FibroScan as well as MRI and PDFF. So, the two NITs that are probably most commonly used is the FIB-4 as well as the non-fibrosis, NAFLD fibrosis score. I think that they're really easy to calculate, and these are kind of things that we would recommend our primary care as well as our colleagues. And then I think the one that we can focus on is really the FIB-4, and we don't have to focus too much on the NFS. So the FIB-4 is really shown to perform a lot better than the NAFLD fibrosis score. The calculators, there's many of them available on our apps. And then it predicts advanced fibrosis with pretty high good specificity. And then with a cutoff of 1.3 and then 2.67. So, there's a couple numbers that you can remember. These are part of 1, 2. It's just, and for the low probability is 1.3, and this is kind of consistent across all guidelines, and the greater high probability is 2.67, and anything in between is called intermediate, which we'll talk about. And the other thing where it's new, and this is adopted by ASD, is really the enhanced liver fibrosis ELF score. It's a proprietary blood test consisting of 3 elements involving really matrix turnover. Thus, this really is a direct marker of liver fibrosis. One is the high uronic acid, which is the glycosaminoglycan that's produced by hepatic stellate cells. The type 3 pro-Golgi peptide, which is a marker for early fibrogenesis as well as inflammation. And a tissue inhibitor of the matrix metalloproteinase. It's a cyclic inhibitor of the MMP, which is the matrix metalloproteinase enzyme that can hence fibrogenesis. So we can see that together, all these three gives you the qualitative as well as quantitative measures of change in extracellular matrix, aka fibrosis. The number that ASD uses on their guidelines is really less than 7.7 is early to know, 9.8 is advanced fibrosis, and when you get above 11.3, it's really concerned for cirrhosis. This is similar to the FibroScan, which is our next slide. When it's greater than 20 kPa on the liver stiffness measurement, then there's a high chance for cirrhosis and can be implemented into the preventive criteria. So the other thing is FibroScan. So then the FibroScan is what we use pretty oftenly. The CAP tells you the steatosis, the liver stiffness tells you fibrosis. The PRO is performed in clinics, real-time results, increased failure rate, of course, with obesity. And then other things like, you want to make sure that the patients is not too morbidly obese because you can use an extra large probe. If they're not having elevated LFTs at the time, which can overestimate your LSM. And then if it's non-fasting state, given that the patient, when they eat, the thought is the blood flow into the liver, causing an increased reading of the LSM. So as long as the patient is not drinking, is fasting for 3 hours, ALT is less than 100, then the reading, or depending on IQR, of course, it's pretty consistent. But then for the fellows on, I think that a lot of people always ask, like, is this a good test or not? Like, can we accept this result? I would say that the FibroScan never underestimates, it does overestimates. So when you have a patient who's like 5, and even though like a 5 kPa, and they have all these elevated ALTs and they maybe ate like 2 hours ago, I think we can still take that test, just because if anything, it never underestimates. So the other thing that we can talk about briefly is the MRI-PDFF. This is really the most sensitive and accurate imaging modality. It's validated to assess dynamic changes in response, and this is really spearheaded by the UCSD group. And now this is more like it's one way that clinical trials are using to have their endpoints. And of course, the cons is really expensive, and as well as just time, cost of the patient, and just expert who's available to read and understand the results. So once you diagnose and suspect now, what's the next step? It's really to evaluate the disease that we talked about based on this a non-invasive imaging test or non-invasive serum test. And we can just cross out the NFS, but just use the FIB-4. And then it's all right. And then for intermittent risk that we talked about, right, the one that in the gray zone, we recommend really next step is the FibroScan or elastography if the patient can't have a accurate or a usable FibroScan, they can use elastography. And then after that, then really biopsy is sort of tried to use the last resort. This is the updated ASD guideline that was just recently published by Ranella, and she did a great presentation on DDW about that. But some updates for us to know is really the risk stratifies the base for advanced fibrosis with FIB-4. Standard ultrasound is no longer sort of recommended for everyone. And you want to screen for type 2 diabetes and all hepatic steatosis, as well as no alcohol in F2 stage. If you look at the algorithm here, it's pretty similar to AGA, but where it kind of differs when they added the ELF score. And so hopefully that explanation of what the ELF score means can be implemented to your next practice. So, all right, so now we talked about sort of, the background, how to get to, risk stratify a patient, how to work up in this algorithm based on AGA and ASD. Let's talk about some treatments and what we can actually specifically recommend to our patients. So really current treatment for NASH is really patient-centered, especially in the absence of FDA-approved therapies, of course, with the goal of reducing disease activity. So aka inflammation, which would then sort of reduce disease progression and fibrosis, with the ultimate long-term goal of preventing cirrhosis as complication, of course, HCC. And the first thing you want to do is really tackle overweight obesity, as that's really the foundational care. And then second, you want to evaluate for any dietary modifiers or cofactors of disease progression. And then third, you want to see if you use any or all available therapies to treat the underlying metabolic comorbidities. So, the reason why weight loss is important, there's a couple of slides, which are the studies I kind of want you guys to remember and always can always use to reference back to. Is really the first one. This is one of the first studies to really investigate the impact of lifestyle modification. This is Villar Gomez back in 2015. He looked at 303 patients with biopsy-proven NASH. And then with lifestyle modification for 52 weeks, low diet, caloric diet, walk 200 minutes a day, as well as had a behavioral session every 8 weeks. And he found that, in 261 patients who had the paired liver biopsy, they saw that NASH and regression fibrosis was observed in the patients with greater than 10% weight loss. And then in another study, looking at more of a systemic meta-analysis of 22 RCTs, including about 2,500 patients with NAFLD, they saw that weight loss interventions consisting of behavioral, pharmacotherapy, or surgical versus none was associated with improved enzymes, as well as steatosis, inflammation, but unfortunately, no significant reduction in fibrosis. And then in another systemic analysis, looking at 23 studies in 6 RCTs, and they saw that weight reduction of about 4 to 10% also increase, and as well as increasing physical activity, improved hepatic steatosis and transaminase. And in another study looking at MRI-PDFF, they saw like a 5% reduction of BMI, resulting in 25% reduction in liver fat. So how do we get there, right? So the weight loss really remains the foundation. How do we sort of help our patients? The first is, of course, diet. It makes it most easy. And this is a study looked at. One thing is easy hanging fruit is just avoiding fructose in general. And it says that fructose is associated de novo lipogenesis, oxidative stress, as well as hepatic ATP depletion. It's associated with obesity, diabetes, dyslipidemia. This is all badness. And this is dependent on daily fructose beverage of greater than 7 per week. That was associated with increased hepatic inflammation and fibrosis. So I usually tell my patients to, this is the first thing is really cut this off. It's easy if you can supplement it with sparkling or soda water. And just try to limit as much as the artificial sweetener as possible. And then the other thing is really, in addition to fructose and refined sugar intake, we can increase, they saw increased consumption of red meat. It's also associated with increased prevalence of NAFLD. So as shown in this figure, you can see the highest quartile of the meat intake had a 3 to 4-fold increase in risk of NAFLD, depending on age, gender, BMI, as well as total caloric intake. So what can we eat? And what's good to eat? So there's a lot of studies looking at low caloric diet, intermittent fasting, but the one that most study is probably the Mediterranean diet, which is associated with greater reduction in hepatic fat compared to really low carbohydrate diets, and to also avoid edible foods like substances. And depending on where we practice at the general here, and sometimes this is easier said than done, right? I think socioeconomic as well as psychosocial factors can play around, and sometimes Mediterranean diets is not possible. So I think that most of our patients, if your clinic has a nutritionist, this is kind of where they can tailor it, where they can coach the patient rather than us just giving us a hand out. But if you had to recommend something, then of course Mediterranean. If not, then just try to do low caloric. Just trying to eat, and then if that doesn't work, then it's really the easiest one is to avoid edible food like substances like potato chips. But then again, this is really hard, especially some of our patients are not the easiest or have the easiest lives. The other thing is coffee, right? So this is kind of easy to this is part of the one that it's part of we drink way too much coffee. And coffee consumption is really associated with decreased metabolic syndrome. They say that greater than 2 cups a day was really associated with decreased fibrosis as well as cirrhosis, and greater than 3 cups a day decrease in liver stiffness. And to think that when the patient always asks, like, can we drink tea? Because tea also has caffeine, but there's something about the coffee where it's a mixture of several chemical compounds, including caffeine, diterpenes, niacin, as well as antioxidants, that maybe has some antioxidants with antifibrotic properties and decreased inflammation. So if you can recommend the patient, it would be just black coffee. And if it's not black coffee, then maybe half the sweetness or a little bit of milk, and try to avoid whole milk if possible. But it's really that black cup of coffee that's the one that's been well studied. And other studies looking at coffee is looking at this meta-analysis, 18 cohorts, 8 case control studies, 2 million patients with 4,000 cases. And these are for patients with HCC. Coffee also shown to reduce a risk of HCC as well as reduce HCC recurrence post-transplant. So coffee all in all is good. So this is really a summary slides of really the nutritional treatment options to refer back to, though the course, through the course of NAFLD. Remission of steatosis can really occur with any weight reduction. And then there's really no evidence of clinical trials on the benefits of merely improving dietary composition that's really shown to reduce NASH or fibrosis. Though it's more of a multifactorial, right? So you eat right, as well as to help decrease weight, and then I will talk about exercise next. All right, so in addition to diet and nutrition, how much exercise is considered beneficial, and what can we do to recommend our patients? So this is a study based on NASH CRN, and they saw that vigorous exercise, which is jogging, running, fast cycling, fast swimming, or just walking briskly up the hill, versus moderate is more like brisk walking, dancing, or gardening. Can be pretty helpful, and in regards to the weight loss. So here in this figure is really, you can recommend the patient 75 minutes per week. That's all, to really help reduce about 35% development of NASH. Now, if you double it to 150 minutes a week, then it's really associated with reduction of about 44% of NASH and also 47% reduction of fibrosis. Now, this is even absent of weight loss. So on top of the dietary recommendation that we give to our patient, we can say, you can describe what type of vigorous exercise really entails, and you can ask them what kind of exercise they do, and we can tailor it to, if it's moderate, just walking or dancing, then we recommend 150 to 300 minutes a week, and if it's vigorous, then 75 to 150. And then, in other studies, looking at prospective longitudinal observation about this, I think the study was 507,000 patients, and they found that vigorous exercise greater than 5 days a week was associated also decrease the risk of HCC. So even more to benefit besides just NAFLD, but also long-term complications. And this is a figure that I think all of us are familiar, and we've seen this multiple times. This is the Villar Gomez study that in 2015 that I referenced in the beginning. And you can see that, with a 3 to 5% weight loss, you have 50% steatosis improvement. And then 5% is really 60% ballooning and inflammation improvement. And then you have 7% loss is 75% NASH improvement. And that 10% is at 45%. We see this a lot, but we forget how hard it is to achieve. And it's, we look at the 10 to 18% of patients who are able to achieve the necessary weight loss. It's even more sad that less than 10% can sustain it. So even though dietary lifestyle is really the foundation of management and NAFLD, and hopefully some of the recommendations that you learn from here, you can give them the tools, but it's really important to sustain it and not just an instant goal. So what about the patients who fail? And dietary and exercise may not be the best option. There's other things that we can do. So available medications. I think that we all know that some of the early trials, the Pippin's trials, we looked at multi-center, double-blind, phase 3, 247 NASH patients, looking at pioglitazone, vitamin E. And they saw that vitamin E was associated with improved steatosis, inflammation, ballooning, as well as NASH. Unfortunately, no improved in fibrosis. And pioglitazone improved insulin resistance, of course, is a diabetic medication, ALT, steatosis, inflammation, but also not fibrosis. And it's one of those things where if we can catch it early, maybe we can stop it in that natural history in terms of NASH to prevent them leading into fibrosis. And I think it's a good drug. I think that there's concern of long-term use and effects really hasn't been sustained or hasn't been proven. But I think the unit that we can recommend to our patients is really 800 units. And the reason why 800 units is there is because they saw that there was increased all-cause mortality when you take vitamin E greater than 800 units, as well as increase in hemorrhagic stroke, and then also increase in prostate cancer. In terms of pioglitazone, sometimes it's not the best for the patient given that there's edema, weight gain, and it's also risk of osteo for women, but though it should be used as one of the backbones in our type 2 diabetic patients who also have NAFLD and NASH. So we saw that, hang on, oh yeah, and then this is one that It's also by Vila Gomez and is more recent, 2020. But they looked at vitamin E as more of a associated with post-transplant, or not post-transplant, improved pre-transplant free survival, as well as decreased hepatic decompensation in patients with or without diabetes. So I think if the patient is coming to you with NASH, with or without diabetes, and the ALT is high, and they try dietary lifestyle, I think vitamin E with 800 units, which you can tell them to purchase on Amazon, I think it's only $13 for a month. It's a reasonable recommendation due to the studies that have shown that's a benefit. And then, contrary to the pioglitazone that we talked about, associated weight gain, another diabetic medication, of course, that we're now coming to more used to using is the GLP receptor agonist, which is FDA approved for obesity as well as diabetes. And this is one of the earliest studies we're looking at liraglutide in the lean trial. They observed that more patients treated with liraglutide had NASH resolution and less progression of fibrosis, and also associated reduction in weight loss, which is also a benefit. And then following that, this is the study looking at in New England Journal in 2021, looking at the semaglutide. And following the lean trial, they saw that semaglutide was associated with increased NASH resolution, but unfortunately no improvement again with fibrosis. The body weight loss was pretty significant in 4.8 up to 12.5%. So which is similar to some of the percentage that we observe in our bariatric patients. Safety concerns, of course, is really common GI symptoms. So I think that if your patient has NAFLD and type 2 diabetes, it's really important that we recommend or start a GLP-1 as the backbone. And if GLP-1 is not, then the other thing is pioglitazone. But on top of their metformin, on top of the other things but improve the diabetic control, as well as improve some of the inflammation, as well as slight fibrosis improvement in the treatment of NASH. So besides the optional medications, I think something we don't talk often enough is bariatric surgery. And bariatric surgery improves both NASH and fibrosis, but of note, just know that it's harder to decrease advanced fibrosis when they have hit F3, F4 compared to earlier fibrosis. So maybe there's this window that we can capture our patients who are maybe F1 and F2. They will probably have the most benefit in terms of regression of the fibrosis compared to the advanced folks. Although we can't recommend that bariatric surgery is used as the primary treatment of NASH, within the context of obesity, we can sort of tailor recommendations. So, usually if patients with BMI greater than 40 who have failed dietary exercise, that's the indication for bariatric surgery. And then if patients who are greater than their BMI 35 with comorbidities like hypertension, type 2 diabetes, hyperlipidemia, OSA, they also indication as well. So I think this is something we can offer, maybe discuss early on if all those other interventions that we talked about does not work. And then in patient comorbid metabolic syndrome, in particular dyslipidemia, I think statins can be a beneficial use in our patient in our population. And I think that although there's no RCTs, they've shown that other RCTs looking at cardiovascular studies show that increase in transaminase, but they actually don't really reflect hepatic injury. Really the best indicator for hepatic injury is total bilirubin. So contrary to what sometimes our consult says, or our primary care providers are less hesitant in using the statins, I think if a patient has cardiovascular risk factor based on an ASCVD score or have dyslipidemia, I think we should recommend a statin. And we would recommend a moderate to intensity statin to improve not only liver disease as well as the cardiovascular risk as well. So we haven't talked about medication, but what about lifestyle? Other thing we could talk about. I think that they saw that patient active or passive tobacco use was associated with increased risk of NAFLD, nearly 8-folds. And this is after adjusting for several factors like age, physical activity, obesity, also metabolic syndrome, diabetes. And also the animal studies show that rat exposure to 2 cigarettes a day associated increased liver enzymes as well as inflammation and fibrosis. That's one thing we tell our patients. On top of everything that we also recommend is really, if they can, to quit tobacco. And one question we get a lot is, what about alcohol use? Is there a safe level? And there's not really any recommended safe level in patients with NAFLD, besides no alcohol use, The heavy alcohol use based on the NIAAA is the 4 drinks for men a week, 21 drinks. 4 drinks a day, 21 drinks a week. For women, it's 3 drinks a day, 14 drinks a week. These are now, I mean, if they meet this, then it's really most likely alcohol-associated steatosis. But I guess in our patients, one thing we can refer back is a study that was published back a couple of years ago, but they saw that about 2,500 patients, I looked at almost the total alcohol use, and they saw that the total alcohol number of alcohol drinks per week was associated steatosis more of a stepwise. And ASD, if you remember the earlier slides, they have came out with now really no recommended alcohol use in a patient with fibrosis stage 2 or greater. So at least we have some direction. But I think for our patients, I think we can recommend if they're early NAFLD, just no an early NASH without fibrosis early stage, we can say moderate, it's okay. But greater than that is none. But again, of course, none is better than some. So one area we can also improve on is really sleep. And this is also for us as well. And in this nice study, looking at sort of a small cohort of patients, they saw that just having more sleep reduced body weight as well as increase a loss of fat-free body mass. So for our patients, if possible, again, at least 8 hours of sleep. So instead of the amount of sleep, also the quality is important as well. And this is really, we should screen our patient for OSA. In the systemic review, they saw that OSA was associated with NASH and fibrosis. So for patients who are obese, large habitus as well as large neck, and has the screen positive for sleep apnea, that's one thing we can recommend to our primary colleagues to screen for OSA. And management OSA can also improve the other metabolic factors such as hypertension, diabetes, and cardiovascular risk. So I left this here is really just, this is the AGA pathway as well, but these are some of the, depending on where our patient falls in, we can sort of recommend their lifestyle, their weight loss, the pharmacotherapy, and then cardiovascular. But hopefully after this talk, you can sort of have a recipe in terms of what do we recommend, and we should recommend specific things, not just to lose weight. So in summary, I think the weight loss, we talked about the weight loss being 7-10%. Though sustainability and achieve is quite hard. The dietary nutrition, we can recommend decreasing complex carbohydrate, maybe decrease consumption of red meat, decrease fructose, of course, increase polysaturated fat, omega-3 fatty acid, which is the Mediterranean diet. In terms of exercise, we would ask them in terms of what kind of exercise they do, and they categorize that as moderate or vigorous, and give them a sort of recommendation in terms of goal, like 150 to 200 minutes a day for moderate, or 75 to 150 minutes a day of vigorous. You want to decrease alcohol use, and we can say for patients with fibrosis stage greater than 2, don't at all. Decrease or quit tobacco use. Try to sleep at least 8 hours a day. Caffeine, mainly coffee, not the tea, but you can have tea, they don't want coffee, it's just that caffeine. For pharmacotherapy, we talked about vitamin E. It's really 800 units daily. And then the PPAR agonist, the GLP-1 with the semaglutide or liraglutide. If they're on liraglutide already, I think it's okay to keep it on without switching. And of course, statins, I think, is underutilized. And we can better educate our primary care providers that statins should not be a contraindication for patients with liver disease. And then for non-pharmacotherapy, it's really the CPAP and obstructive sleep apnea. Bariatric surgery can be talked a little earlier, as well as age-related cancer screening. Yeah, hopefully that was helpful, and then you guys can use these tools to implement your next time you see a patient with NAFLD. Love for any questions.
All right, thank you for that comprehensive evidence-based review, Nghiem. I had a question, so just to kind of consolidate things for like a take-home message here. Let's say you had that initial clinic visit with an obese patient who has diabetes that's not perfectly controlled, and they have biopsy-proven evidence of NASH. In terms of pharmacotherapy, what's your kind of step-up approach to what sort of things that you'll add on in order, or would you do
This is a diabetic patient or non-diabetic patient?
Diabetic patient. Yeah.
But yeah, I think that's, we can get these referrals a lot. I think one thing is understanding or taking a look at the diabetic medications we have. So most people are placed on metformin. And for the fellows on, there's been a lot of studies looking at metformin as a monotherapy use. There's some conflicting evidence for sure. And because the conflicting evidence is not recommended as the primary modality to actually have any beneficial for NAFLD or NASH, and should definitely not be started if they're not diabetic. So I'll take a look at that. Usually the metformin is the backbone that everyone patient have. And then if they're on another second agent or third agent, what I would do is really consolidate that and see if they would benefit being placed on a pioglitazone, like a PPAR or a GLP-1. And using that as well as the metformin and the insulin, I would try to consolidate that as the first line and see if we can, pull back on some of the other diabetic classes. And then the other thing is I would look at sort of their lipid profile, because when you're diabetic, usually you have this metabolic trifecta. And that's when some of the patients that we see in our clinic are not on statins to begin with. And that's when we can recommend placing on a moderate statins if the ACVD risk is not too high. If it's really high, then of course placing a high statin, high intensity statin. And then just putting that in our note to recommend, or even starting it ourselves, will kind of help the primary care provider be less hesitant and actually start that statin in general. But I would start with that, and then most likely can really effort to control the diabetes. And then rather than starting everything, like say like vitamin E, I would hold off of that and try to control diabetes first, and that way hit two birds with one stone in their liver disease and also the cardiovascular.
And given that a lot of these study outcomes potentially only reach things like resolution of NASH without necessarily the fibrosis, how do you think about like duration of use, or do you leave them on these therapies indefinitely, or do you think about like a time limited trial? How do you think about that?
That's a really good question. I think that most of these medications, so none of these are actually the approved medication we talked about. They're not recommended for patients who specifically have NASH as a sole disease, and they're always paired with like another type of comorbidity like type 2 diabetes. So I think that if they're on these medications already and there's some benefits of NASH and NAFLD, that would just continue on while monitoring how well they do in their other comorbidities, like their lipids or their A1C. And then, most of the studies that's coming out now, we didn't talk about, but there's the thyroid receptors, as well as lanifibranor, that's the pan-PPARs. Those are all phase 2, and they're going to be phase 3 results hopefully in the next couple of years or soon. Those did show some improvement of fibrosis. So for those patients who don't fall in our buckets with diabetes or dyslipidemia, maybe those medications can be started on, and those are more for fibrosis.
All right, great, thank you. Any other questions from the group?
Yeah, thanks everyone for coming. Really appreciate it.
All right, thank you, Nghiem. And with that, we'll conclude our talk.
Thanks, Nathan. Have fun, man. Safe travels, okay?
Thanks. That was impressive, Nghiem. Did you make this talk for this? Or? Wow.
Yeah, I did it for the I did it for our residency.
I see.
For the fellows. But I think that the grand rounds are for our fellows. We couldn't make room. But it's frustrating because we always get these talks where like recommendation, but I want specific recommendation I can actually use my notes. You know what I mean? Yeah. So then I tailor it to that way. It's more clinically useful than rather than theory. Like we get so many pathophysiology lectures that we don't need anymore.
Yeah, well, we'll see when the genetic testing stuff for NAFLD will come into play. I don't know. Do you think that'll ever come to play clinically, like testing for genetic?
Yeah, dude, that's like, I mean, that's like
Like a whole
another
other
hour
thing.
talk. But I
Yeah.
mean, yeah, I think that, there are definitely there's a couple, the one that we get tested on is a PNP
PNPLA.
on the boards, but then there's others, ones that are, I mean, the Lumba group that, if you were there for, he talked a couple weeks ago, but they're working on a couple different ones, and, maybe we can identify these patients sooner. I mean, the goal is really to capture them sooner, to target these therapies, start them on, and prevent them for long term. But I definitely think genetics um, factors are maybe early predictors for like fast progressors, because that epidemiology graph that we showed, there's 20% of them that progress way faster than that 14 years that we kind of estimate per stage. So who's those 20%? We can treat them earlier, then that'd be awesome. But for sure, maybe not right now, not in prime time, but maybe in a decade from now.
Anyways, all right. Thanks, team.
Cool, man. I'll see you later.
All right. Bye.
Bye, everyone.